Welcome, everybody. It's my great pleasure to announce first speaker of the third Grand Round series in cardiovascular imaging. It's now our third year that we do this very successful Grand Round series with a renowned speaker from all around the world. And second, it is my very, very great pleasure that we can welcome today Rozemarijn Vliegenthart. Professor Vliegenthart is professor of cardiothoracic imaging and radiology at the University of Groningen. She is also in cardiovascular imaging at our best journal, Radiology. He's since a few weeks the past president of the European Society of Cardiovascular Radiology, and many other things that I will not mention now. And she has agreed to give a lecture today in this series, which is really great for us and for people who listen. And the topic, I think, is very intriguing and very exciting. And it's about the heart in lung cancer screening. What should we look for and why? Thanks, Rozemarijn. One last comment. Please, when you have questions, type them in the chat, and we will then read them afterwards. Then we'll have a short. Thanks, Rozemarijn.
Thank you, Hatem, for the invitation for this Grand Round lecture and for the introduction. It's my pleasure to contribute to the start of your third series. Indeed, this is a topic that is really gaining a lot of attention right now with the current introduction of lung cancer screening. One of the major questions is what should we do with other findings on chest CT and in particular coronary calcifications. These are my disclosures, and none are very directly related to this topic. So what I'm going to talk about in, say, the next 25 minutes is, first of all, the importance and the predictive power of coronary calcium assessment. Then the question, can we combine coronary calcium assessment and lung cancer screening, and how to do this practical implementation of coronary calcium assessment in chest CT. To introduce the topic why we should look at the heart and in particular coronary calcifications in lung cancer screening, I would like to first start with the current role and the importance of a coronary calcium scan, because this is the background for the current interest in lung cancer screening. So a calcium score scan is a non-contrast ECG synchronized scan of the heart, generally at 120 kVps tube voltage. The reconstructed slice thickness is 2.5 or 3 millimeters in a field of view of 250 millimeters, and it's done with a filtered back projection. And this protocol basically has been the same for over 30 years now and was first described for electron beam CT. Also, the method of how we quantify coronary calcifications originates from that time by Eggleston, a cardiologist who thought of a way to quantify the amount of coronary calcium. And this is done by multiplying the area of high density voxels in the coronary arteries by a factor that is dependent on the voxel with the highest density in a particular calcified lesion. And by adding all these calcification scores up, you get a total calcium score for the entire coronary tree. And this is what we use in clinical practice. And from numerous studies, including phantom studies, repeat CT scans, and all kinds of cohort studies, we know that this is a very robust imaging biomarker that is reproducible and accurate. And I think one of the most robust imaging biomarkers we currently have in radiology. Here are just 4 examples of individuals with different amounts of coronary calcium. Left upper, you see no calcified spots in the coronary arteries, calcium score 0, but the calcium score has a huge range and can go up to more than 2000, as you see in this case on the right lower side. Multiple population-based studies, some including a true general population and others more health screening populations, have shown the strong predictive value of the amount of coronary calcification for cardiac outcomes. And taking the results of all these studies together, and this is already published in 2008 in New England, it shows that the increasing amount of coronary calcium in standardized categories shows a very strong relation to the risk of cardiac events, where already the presence of coronary calcium, of a calcium score of 1 to 100, doubles the risk of events compared to a calcium score of 0. And this goes up with the relative risks of 4, 7, and 11 for those with a calcium score of 100 to 400, 400 to 1,000, or over 1,000. These kind of risks are higher than we find for regular cardiovascular risk factors like hypertension and smoking. And newer studies have shown that the calcium score is also a predictor in young populations and in old populations and in the different races and ethnicities. And by now we have pooled studies of more than 66,000 individuals with a follow-up of over 10 years that show the long-term predictive value of coronary calcium. And here the outcome was mortality. You see here on the left side, coronary heart disease mortality, then cardiovascular disease mortality, and all-cause mortality. And I think there are two really important things here. One is that the long-term risk of mortality is very low when you have a calcium score of 0. And you see a very strong relationship between the amount of calcium and the event rate, with quite high event rate in those who have a calcium score of 1,000 or more. So this calcium score of 0 is really important in clinical practice. And in this talk, I will not go into the potential role of calcium scoring in clinical patients with symptoms of coronary artery disease, but these are data merely on asymptomatic populations. And you see in this graph, in this Kaplan-Meier curve, that already there is a difference in the event rate and the event-free survival rate for those who have a calcium score of 1 to 10 compared to 0. So there's truly a power of a calcium score of 0. Now, what do the guidelines currently say? And I just first show you what the guidelines say on the role and the positioning of coronary calcium scoring, and then where we are with regards to the strength of the recommendations. So in cardiovascular risk scoring, which is commonly performed either by GPs or in clinical practice by internal medicine specialists or cardiologists, the standard way of doing this is starting with evaluation of cardiovascular risk factors. And based on that, you can derive a risk score, which is low, intermediate, or high. And while it's pretty clear what to do in those with a low risk and high risk, there's less certainty on the need for medication in those with an intermediate risk. And here the recommendation is to use a risk modifier, such as the calcium score, to know better what the underlying amount of coronary atherosclerosis is. So this means that in this group, a calcium score can be used to either risk stratify downward if the calcium score of 0, so then the risk is low and no further preventive treatment is needed, or in case of a high calcium score, which is generally expressed as the calcium score of 100 or more, or an age and sex percentile above 75, then an individual is upward stratified and does benefit from lifestyle modifications and preventive medication. And this is a more recent overview of all the different guidelines and practice recommendations at this moment on coronary calcium scoring, and they all basically use the same criteria of calcium score of 0 and 100, where above 100 is used to initiate statin. Importantly, the strength of the recommendations currently is not at a class 1, level 1 yet, mainly because we do not have a trial that shows that management on the basis of the calcium score improves long-term outcomes. What we do know from multiple studies where, for example, calcium scoring was used to monitor the effect on risk factors is that the calcium score by itself can reclassify those in this intermediate risk category of about 52 to 66%. And then these individuals end up in a better risk classification category. And the calcium score in terms of discriminatory power outperforms risk factor-based scoring methods and other atherosclerosis markers. And for example, data from MESA have shown that the calcium score is more effective at identifying individuals who do or do not need statins, and that sharing the calcium score with an individual can help to improve long-term lifestyle and statin adherence. But as said, to get to a level 1 recommendation, the general idea is still that we need a trial that will show what the effect is of the calcium score on long-term events. This is being studied right now in the Robinska trial in the Netherlands. Now, let's turn to the second question. So now that we know that this calcium score and the amount of coronary calcification really is important to identify those at elevated risk or very low risk, can we use this evaluation also in lung cancer screening? The background is that, of course, the heart is visible on a chest CT, actually on any chest CT, not just in lung cancer screening. And with the increase in scan speed and quality, we often see much more of the heart than on prior generations of scanners. So in quite many scans, we can now see the heart with very limited motion. Sorry, that was the doorbell. And that means that we can also see if there are coronary calcifications. Plus, the amount of chest CTs that are performed are way larger at this moment in clinical practice than cardiac CT scans. And so this could provide us with an opportunistic screening for cardiac risk beyond the mere indication for the chest CT. Furthermore, we know that lung cancer screening is on the rise, and there are starting programs in a number of countries in Europe. From previous studies, we know that coronary calcium is actually visible in 50 to 80% of chest CTs, but in 44 to 69%, this is missed or not, at least not reported on the chest CT scan. So this is, I think, a teaching point for all of us. When we look at the indication for calcium scoring, this is the intermediate risk population based on cardiovascular risk factors. But it's important to realize that those who have an indication for lung cancer screening, so long-term smokers, generally older individuals and mostly men, nearly all of them have at least an intermediate cardiovascular risk when you put in these data into a risk scoring system. So basically, the lung cancer screening population is a perfect cohort to also look at the risk of cardiovascular disease. And also we know from, for example, the National Lung Screening Trial, but also the Dutch-Belgian Nelson trial, that the mortality in the lung cancer screening population is basically the same for cardiovascular disease compared to lung cancer. So we could really increase the efficiency of lung cancer screening if we would directly also look at those with an elevated risk for cardiovascular disease. So in screening, in lung cancer screening, it is less important to rule out those with a calcium score of 0, because in this setting, you're really looking for those who have an elevated risk of cardiovascular disease, so you can start statins. So that means that we should be focusing on those who have a calcium score of 100 or more. Now, when we look at the scan protocols for lung cancer screening, is for detection of lung nodules and coronary calcium scoring, and this is from a review we published some years ago, there are quite some differences. So, for example, in lung cancer screening, we do not use ECG synchronization. The tube voltage in lung cancer screening can vary from 80 to 140 kVp, depending on patient size, while in coronary calcium scoring, it's basically fixed at 120 kVp. Furthermore, the lung nodule, the lung cancer screening CT scan is usually a low-pitch spiral, while in coronary calcium scoring, we either use a sequential mode or a high-pitch spiral mode. So all of these factors can affect how visible coronary calcifications are, but possibly also what is the actual calcium score. When we're looking at the reconstruction protocols, again, we see a number of differences. For lung cancer screening CT, more and more iterative reconstruction is used because that reduces noise, which helps then to further reduce the dose of the low-dose CT scan. There are different kernels used in lung cancer screening, and the field of view is different as well. And lastly, the thickness of the slice thickness in lung cancer screening CT is about 1 millimeter, while for the calcium score scan, we need 3 millimeters. So if we would like to combine different disease screenings into one low-dose chest CT, there are different options to do that. If you want the most robust and accurate biomarkers for all the different diseases, including lung nodules, perhaps also emphysema and air trapping that I will not address here, and calcium, of course, the best thing would be to do individual scans for all these different parameters. But that would not only increase the time of the scan, but also the dose, which of course is a major issue in a screening setting of a presumed healthy population. So what we would like to do is just use one and the same lung cancer screening CT acquisition of the whole chest to then also derive the information on coronary calcium. How can we do that? Well, there are a number of studies that have investigated what is the effect if you want to look at this coronary calcification on chest CT. And there are studies that have used in the same cohort a dedicated cardiac CT scan for calcium scoring and then compared the outcome of the calcium score to the low-dose chest CT made at the same time. And you see here one example. The top shows you the ECG-triggered cardiac CT, and the bottom shows you the non-ECG-triggered chest CT with a reconstruction focused on the heart. And you see, first of all, that small calcifications can be missed. There's a small calcification in the RCA, which is not visible in the chest CT due to motion. But you also see a difference in quantification. Again, there's more motion in a chest CT, which generally results in these kind of motion artifacts that reduce the calcium score. So basically, you can have an underestimation of the amount of calcium in chest CT. And we investigated this years ago already in a meta-analysis where patients and screenees underwent both a chest CT and a cardiac CT. These were with older CT scanner generations, but they all reconstructed the images with 2.5 or 3 millimeters. The sensitivity for any coronary calcium was quite high, 91%, but a high calcium score, and in this particular study diagnosed as more than 400, was underestimated in 19%. In a much more recent meta-analysis, by now 6,500 individuals could be included. They also used new CT scanner generations, including 256 multi-detector CT and high-pitch third-generation dual-source CT. The sensitivity is higher, 96%. The overall agreement in risk categorization for the calcium score is very good, with a pooled kappa of 0.84, with a mass classification to a lower risk category in only 6%. So it seems with newer scanner generations and also faster acquisition techniques that the result for the calcium score becomes closer to the original cardiac CT scan. And this is one specific study that used third generation dual source CT, and they compared the cardiac CT to ultra low dose chest CT with a tin filter, and they used the same reconstruction. And again, they found a very strong correlation and substantial agreement, but they actually found 31% in a different risk category, and 28% of those with a high calcium score of more than 100 were missed. So it seems even with new scanner generations that we still find underestimation of those with a high risk. I think for the future, it will be important to use different phantoms that we already used in older scanner generations to really find out what would be the best quantification acquisition of the calcium score in chest CT and the correct best reconstruction method. And we need to standardize that because with repeated lung cancer screening CT scans, through the years, it may, of course, happen that different scanners are used and newer scanner generations. Now, another approach to evaluating coronary calcium in chest CT is not quantifying it, but just use a visual assessment. And this does not require software. You can just, any radiologist can do it when he looks at the scan. And you see here a ranking of absent, mild, moderate, and severe, which closely resembles calcium score of 0, 1 to 100, 100, 1 to 400, and over 400. You see here 3 examples that correspond to mild, moderate, and severe coronary calcium. And an alternative to that is an ordinal score, where you basically do a semi-quantitative analysis per artery, but then including each individual segment. This is a bit more work than just doing one overall evaluation with the visual ranking. So if we would use that, then we just need to look at who has moderate or severe coronary calcium to identify those at high cardiovascular risk. So how good is that? Well, there are actually studies that compare this visual assessment to the actual quantification on a cardiac CT scan. One thing that I think is important, this was a study from nearly 1,000 individuals with different CT scanners, that the sensitivity of this chest CT, again, was not optimal for coronary calcium, 76%, so 24% of those who had a positive calcium score had a 0 calcium score actually for those in the chest CT group. But furthermore, using this simple moderate and severe calcification ranking on chest CT missed 38% of those with a high calcium score. So I think this is not good enough actually to use in chest CT screening. But when we're looking at the actual prognostic value of coronary calcium scoring, or even using this ordinal score or visual ranking on a chest CT, and this is from the NLST data, so the lung cancer screening study in the US, you see that even if the calcium score is not optimal, the relative risks are quite high, with a relative risk for those with the highest calcium score or severe coronary calcium on visual evaluation of 7. So even though this kind of chest CT and visual evaluation is not as good as an optimal cardiac CT scan with optimal calcium scoring, even in chest CT, it is a strong predictor of cardiovascular events. So how can we in the future still implement this kind of calcium scoring in chest CT? So first of all, I think it's important to realize that those that do have moderate or severe calcium and a high calcium score, you're pretty sure that they also have a high calcium score if we would do a cardiac CT scan. So this is a good finding to report so that people can start statins. On the other hand, if we want to do a large-scale screening program, we would like to maybe do all this completely automatically, instead of that a radiologist needs to look at the visual scoring of the calcium score or even do a calcium score software evaluation. And actually, we did this study with an AI product for calcium scoring that was actually based on a cardiac CT scan. And it found a very high correlation for manual scoring versus AI scoring, and also compared to the cardiac CT scan, with 70 to 82% agreement categorization. So I think we're getting closer towards having automated AI-based software that can help us to do these kind of evaluations automatically, also in clinical practice. So how should we go about practically implementing coronary calcium assessment in chest CT? And by now we have 4 different documents that give recommendations on coronary calcium in chest CT. And the latest one, and the only one really that is focused on the use in lung cancer screening CT, is the right lower one. It's a multi-society statement, including ERS, etc., on a management of all incidental findings in lung cancer screening CT, including coronary calcium. And actually, the recommendations are very similar. First of all, they all state that coronary calcium should be evaluated and reported on chest CT. So that's take-home point number 1. And the second thing is that coronary calcium should be estimated as none, mild, moderate, or severe. So this is the visual evaluation where the calcium scoring, so the Eggerson calcium scoring, could be used as an alternative. Of course, this will depend on if you have easy access and easy integration of this calcium scoring in your current chest CT workflow. And the next and last recommendation from these statements is if there's moderate or severe coronary calcium, then there should be primary care review of cardiovascular risk factors and checking the need for statin evaluation, for statin use. For the role in lung cancer screening, we have 2 European statements that specifically mention what they think should be done with coronary calcium scoring in screening. And the ERS statement from 2020 said, reporting could be considered, may transform lung cancer screening into an attractive prevention program for high-risk persons, needs to show whether therapeutic or lifestyle interventions lead to actual benefits. So this is still to be proven in a lung cancer screening setting. And the initiative for European lung screening states most screenings are also high risk for CVD, evidence that calcium identifies high-risk patients and that treating them with statins improves outcomes. Thus, reporting calcium enhances benefit, but many questions to be answered. So what are these open questions? And these are just some questions that I have when I review the entire literature and the field. So first of all, I think what we need to answer is visual scoring accurate and sufficient, because that is a major decision if we start implementing this in lung cancer screening. Because if not, then we'll have to do calcium scoring. But calcium scoring is more dependent on your actual calcium, your scan protocol and your reconstruction protocol. So then it becomes really, really important that we define how to the specific criteria for performing the scan and the reconstruction protocol. So one question then is, how do we deal with the different tube potential in chest CT as is currently performed? Also, the question is, do we need a specific reconstruction? So meaning 2.5 or 3 millimeter slices on a field of view of 250, or can we use the actual chest CT images that we already have? Another question, and that would really influence how we would do lung cancer screening, is do we need an ECG synchronized chest CT to optimize the calcium score? And lastly, does ultra-low dose chest CT, which really is the next step for implementing lung cancer screening, allow accurate calcium scoring? And there we need to do more research. There's one paper, one study that has actually looked at implementing calcium assessment in lung cancer screening. This is the lung screen uptake trial in the UK, in which nearly 700 smokers and ex-smokers had cardiovascular risk assessment, and they derived the Q-risk2 score, which is a specific risk score for cardiovascular risk. And then they checked how many of these individuals were high risk. And actually, they showed that while 98% of those had high risk and would qualify for statin use, only 43% actually used statins. So statins was underused, and also a lot of individuals probably didn't know that they were at elevated risk. They found coronary calcium in 62% of these individuals, severe is 7%, severe was more than 400. And interestingly, on the other hand, in those with an intermediate risk, in 55% they found no calcium. So it seems even the amount of calcium in a lung cancer screening setting can stratify into low and high risk. In conclusion, coronary calcium is a very strong predictor of cardiovascular disease, even when using a suboptimal method such as chest CT. Even visual evaluation of moderate or severe coronary calcium in chest CT identifies those at elevated risk that may benefit from preventive medication. And lung cancer screening provides an opportunity to identify those at high cardiovascular risk, but we need to work further to answer the last questions in this field. Thank you for your attention.
Thank you very much, Rozemarijn. Excellent overview over this intriguing topic. Now, I don't see so far questions in the chat. I could perhaps start with a question. Now, we discussed the protocols and the accuracy and the concordance between a non-gated chest CT and a calcium. Perhaps it would be good, like a statement from the ESCR in collaboration also with SCI regarding this topic, how to proceed. To Professor Albert from last week. He also mentioned that everybody does a bit what he wants. There is no uniformity in protocols. Therefore, in calcium scoring results from lung cancer. So it's important to have some information here. What is your opinion?
Yeah, absolutely. I think that there are currently let's say initiatives to start talking about this, to get together a writing group on this topic, because now that lung cancer screening is really getting closer to implementation in Europe, in the different European countries, and there's already pilot programs starting in different countries, it becomes a really acute question, because you may want to directly use this information in the chest CT, but then you really have to have a good method to do that. And one point, of course, that's also really important is what to do with this information, because you don't want to flood the primary care, for example, and they'll say, what to do with this? I don't know what calcium score is, and now all these people come to me. So we need really clear management advice for the different calcium score categories, or the visual evaluation, etc. So I think it would really benefit if we would, get together the different societies in Europe that are closely related to lung cancer screening to define how we would implement this.
Okay, thank you. There is a question here, Robert.
Yes, thank you also from my side, Rozemarijn. Fantastic overview. It was really interesting to see all the fine aspects of calcium screening in patients with cancer. So let's start with the first question from the chat. It's from Lisa Jungblut. And the question is, could you comment on cost efficiency on lung cancer screening when reporting calcium scores? Is there any data around?
Well, we actually published this, I think this year in European Radiology. This was one of the questions we had. To what extent does cost efficiency, is it impacted by looking at, well, we also included emphysema. So we used basically the lung nodules, which we have many studies showing the cost effectiveness for lung cancer screening. We focused on what happens if you add emphysema screening as a sign of COPD, and what happens if you also add calcium scoring. And what we found is that particularly adding calcium scoring improves the cost efficiency, the amount of money used to gain one quality life, so the number of life years gained. I think those results are encouraging. There are very few studies out there at this moment that have compared this. So I think we need to look in the different populations, because of course the cost efficiency will also depend on the specific population that you will choose for lung cancer screening.
Okay, thank you. There is no other question. So I would just ask a simple question. You said at the beginning that it's not reported in so why is that? Is it just because people are not aware of it, or is cardiac still, while reading, just something in the middle and I'm not so interested? So, or what is it?
Well, the studies I reported, I don't think they looked at the actual reasons why this is not better. I think some could be because traditionally we haven't been able to say much about the heart because of the motion. And not everybody is maybe educated about what is moderate or severe coronary calcium, which in itself is not very difficult to learn, but you need to have a number of examples. Say, okay, oh yeah, so this is moderate, this is severe, okay, because you don't want to overcall things either, right? So you don't want to put any mild coronary calcium in your conclusion of any CT scan, and then just overburden the healthcare system, because everybody's gonna, okay, so what now? So we should only report, at least in the conclusion, what is clinically relevant and will lead to management decisions. And I think for moderate or severe coronary calcium, this could well be the case, because people can have primary care evaluation of risk factors, get statins. And so personally, I do put it in the conclusion. For example, for a person who is up for lung cancer cases, for example, that go up for surgery, because there it's really important information to know that somebody's at elevated cardiovascular risk perioperatively. But I think it's just that we just overlook it often, or we just don't have the habit of always looking at coronary calcium and just writing it in our report. So this is, I think, a teaching point for all of us to just, if you make it a habit, you won't miss it anymore.
Yes, I also thank you. I also think that also for a cardiologist, then reading the report of the chest CT, I'm not sure if every cardiologist would react actually reading this calcium there. So also from the other side, they should be trained on getting this information as well, right? So they would react, because I'm pretty sure that
absolutely. I think it's important because chest CTs are requested by so many different clinical partners that a lot of them don't know what to do with that information at all. So possibly it would be better just to write not only moderate or severe coronary calcium in the conclusion, but combine it with a recommendation according to the statements that the consensus documents that are out there. so that people directly also know what to do with this information. So that can help everybody, I think, to to have an efficient follow-up of this. And there are now specific programs, but that takes more effort, but specific programs where they look up the information on chest CT, on coronary calcium, and then actively give that information to the patient and to primary care. And these are trials going on in the US that show that really has a good effect on the level of statin indications in those individuals that would otherwise probably not get it.
Yeah, that's clearly important in this setting. Hatem, do you have something as well, or more?
One thing that is perhaps too complex to answer now in the short left time, and it goes back to the topic of the costs. I was recently asked by a chest surgeon here in Zurich, because screening program is to start, and she told me now from which calcium scoring result in this chest CT performed for lung cancer screening should we send the patient to the cardiologist. The cardiologist said, okay, when there's calcium, send us the patient, have them in our, and then we do, of course, because every human in our hospital gets an echo, at least one per day, I would say. And then they need also, of course, treadmill test, and I think then things get out of control, and then it's no longer cost effective. Then I think this is the end of every lung cancer screening. Can we keep the bird, in the?
I could imagine that if this becomes a regular part of lung cancer screening, then the management also becomes the recommendation could be part of the evaluation that a screenee will get directly after exiting the screening. So I don't think it's cardiovascular risk management of those who have no symptoms belongs in a hospital. It should be in primary care. And this is so standardized management that I could imagine that you don't even need to go to primary care for that entire evaluation, but that you can make that part of your lung cancer screening program, which will probably be the most cost efficient.
Okay. Okay, thank you very much. Yeah, I think it's now 1:45. I think we can close the first webinar now on this topic. Thanks again, Rozemarijn, for your participation.
Thank you.
So thank you again from my side to Rozemarijn Vliegenthart and to all the participants, and also our back office for helping us in the organization. Thank you, and wishing everyone a nice day.
Bye-bye.
Thank you, everybody. Bye-bye. Thanks, Rozemarijn.